Good day, everyone. Saludos a todos. Con esto comenzamos nuestro webinar hoy. With this, we'll start our webinar looking at optimizing physician collaboration with community health workers in both HIV prevention and care. We believe this topic is very timely and it is vital for improving the health and equity for HIV patients throughout the community. Next slide, please. A little learner notification, the webinar itself is free. However, if you do like CME credit for participation in today's webinar, if you're an NHMA member, it will be free as well. For non-NHMA members, it will be $25. You can get information about how to receive this later on after the webinar is completed. And it'll take about a week or so to receive all the credits. Thank you. Next slide. I'd like to present myself. I'm John Ernest McKinnon. I have been providing HIV care since 2002. I had the pleasure to work in Pittsburgh, Detroit, and now in Charleston, South Carolina. I have been focusing my HIV care in both general HIV patients, but also in underserved communities, particularly Hispanic patients, which I provide care for the last 20 years or so. With that, I would like to move on to a little bit of housekeeping items. Please have all your microphones muted to avoid any feedback loop. This will allow us to hear better the presentations. Any questions you may have, please submit them to your Q&A box for discussion. All the questions will be discussed at the end of the webinar. The webinar will also be recorded and the resources will be provided. You may be able to find the webinar at the NHMAMD.org website or through our YouTube channel. Thank you. A little bit about NHMA. This is the National Hispanic Medical Association. We've been established since 1994. We are a 501c nonpartisan association and represent about 50,000 licensed Hispanic physicians within the United States and its territories. We have the vision of our organization is to become a national leader in improving the health of our Hispanic population, not just our HIV patients. Our mission and organization is to empower Hispanic physicians to lead the efforts for care in both Hispanic and underrepresented communities and promote collaborations between medical societies, residents, medical students, public and private sectors. Thank you. Today we have an excellent panel. We'll have both Jacqueline McSparron from the Erie Family Health Center. She is the medical director at the facility. She will be talking to us today about her experiences, as well as Marta Robles, who's a peer navigation coordinator at Christine's Place in San Diego, California. We are blessed to have them both here representing our patients and our healthcare workers. Next slide, please. With this, I'd like to introduce more formally Jacqueline McSparrow. Again, she's the site medical director for Erie Humboldt Park for the Erie Family Health Centers. Jacqueline's presentation will explore the clinical and systemic factors that impact HIV care, and as well as including healthcare, looking at the healthcare disparities that we see in our population and what social determinants of health can impact HIV care for our patients from the perspective of HIV specialists. With this, I would like to pass over to Ms. McSparron and begin her wonderful talk.
Thank you very much, Dr. McKinnon. And thank you very much for having me. I'm very excited to speak about this topic that's very close to my heart. As Dr. McKinnon said, I am the site medical director at Erie Family Health Center's Humboldt Park location in Chicago. I'm also the clinical director of our HIV treatment and prevention program, where we serve almost 600 patients living with HIV, and also provide PrEP to about 150 more. Next slide, please. So I think anytime we talk about HIV care in the real world, we need to talk about disparities from the delays in the early days of the epidemic related to those people who were at risk, to today with the racial and ethnic disparities. In the United States, disparities in HIV infection and prevention rates are glaring and really demonstrate how certain communities have been left out of this discussion. So, we're going to start off talking about some of the racial and ethnic disparities in HIV infections. So, this data is all from AIDSview, which is a really fantastic website if anyone is interested in sort of the demographics of HIV. So, in 2023, these numbers are compared to the rate of HIV diagnosis in folks who identify as white. So, folks who identify as Black had an 8.4 times higher rate of new HIV infections, and folks who identified as Hispanic or Latino had a 5.2% higher risk of being diagnosed with HIV. Next slide. Looking at this in a different way, folks who identified as Black accounted for 38% of new HIV diagnoses, but they only make up 12% of the United States population. Similarly, folks who identify as Hispanic or Latino accounted for 34% of new HIV diagnoses, despite representing only 19% of the general population. So we see that these populations are really bearing the highest burden of new HIV infections per person. Next slide. We also see disparities in control of HIV. So, for those who are not familiar, there's something in the HIV world that we call the care continuum. So, how many patients know their diagnosis? How many of those patients are linked to care? How many of those patients are retained in care? And then, how many of those patients reach viral suppression? So, this you can see that the dark green is folks who identify as Black. The lighter green is folks that identify as Hispanic or Latino, and the orange is folks who identify as white. And so folks are actually linked to care at a similar rate, but folks who actually are established in care and receive care are lower in our African American, Black, Latino, Hispanic populations. And those patients who are virally suppressed, so the folks who have a viral load that is undetectable, are much lower in our folks who are either Black or Hispanic Latino. This puts these folks at higher risk for complications due to HIV. It also means that they are able to transmit the virus as opposed to the folks who are virally suppressed, those who are undetectable. Next slide. So this slide discusses PrEP, so HIV prevention. It is clear that PrEP is not reaching the people that are most at risk for HIV. So this slide shows what we call the PrEP to need ratio. So for every one person who will be diagnosed with HIV, how many people are taking PrEP or pre-exposure prophylaxis? So for people who identify as white, for every one person who gets diagnosed with HIV, almost 42 people are taking PrEP. For people who identify as Hispanic and Latino, for every one person who is diagnosed with HIV, 7.9 people are taking PrEP. And for folks who are African American or Black, that number is only 5.8. So our folks who have the highest rates, the highest risk for new infection, are not the folks who are taking medication to prevent HIV. And this is really where not only clinicians, but community health workers and care managers really come into play. Next slide. So, case management. I work with an organization, and our program for HIV treatment and prevention is funded by the Ryan White program. Through the Ryan White program, we are able to have, and fortunate to have, really phenomenal case managers and community health workers. This data is from Chicago, where I am. So the dark blue line is those folks in Chicago who are known to be living with HIV and who have had a viral load in the past year. And so you can see that in 2023, which is the last year we have data, only about 6% of those folks are virally suppressed. The light blue bar is folks who are in Ryan White organizations, and so necessarily have the option of case management. 90% of those folks were virally suppressed. And most of these programs tend to focus in underserved areas. And so it's really telling that our folks who are case managed, who have access to this and other services through Ryan White, are really able to attain that viral suppression. All right, next slide. So I don't need to tell anybody the information that this chart shows, that folks who identify as Black or Hispanic Latino have higher needs in our social drivers of health. But it's always good to see it. So folks who identify as Black or Hispanic Latino, and these are folks who are living with HIV. This is not just the general public. These folks are more likely to live below the poverty line than folks who identify as white, are more likely to be uninsured, to have less than a high school education, and to be food insecure. And in the past decade or so, it has really come to light how vital this is, the social drivers of health or the social determinants of health, how much that affects a person's ability to live a healthy life. Just one example, if a person is food insecure, there are HIV medications that have to be taken with a 500-calorie meal. If you are food insecure, you may not be able to appropriately take those medications and may not reach food viral suppression. Similarly, people who live below the poverty line often have transportation issues. You can't get to your visits. You can't get to your pharmacy to get your medications. And so that's really where the community support is vitally important. Next slide. I was not able to find any information about language concordance or the shared language for community health workers, case managers, and patients. But this data is from folks who have providers. So it looks at provider language. So there was a study that showed that patients with limited English had a poor diabetes control. However, if that patient had a provider that spoke their language, that was not the case. They had the same diabetes control as folks who spoke English proficiently. Other studies showed improved patient satisfaction in people who are living with diabetes and who are living with cancer. Another study showed that language concordance between a patient and a provider results in lower utilization of specialists, less inpatient care, fewer emergency room visits. It just supports the patient in a different way to be able to communicate in their preferred language without having to go through a translator. Next slide. So why is that? Why do people with case managers or community health workers do better? Goal setting is really one thing that we try to focus on in our practice. Again, as part of Ryan White, we are required to set goals every year and to monitor them. And those goals are not just clinical goals. Certainly, we monitor viral suppression. Certainly, we monitor engagement in care. But we also monitor patients' dental visits. And that's really looking at the whole person and what affects them outside of just, their medical visit. Cultural understanding and community connections, I think, is perhaps the most valuable, especially with our community health workers. I speak Spanish. I can speak Spanish in my visits, but I do not come from the communities that my patients come from. I can talk to them about PrEP, but that's me who is not, has not lived their lived experience. If someone that can relate to them, that knows their community, can talk to them about PrEP or about HIV care or about STI prevention, it goes a much It goes much, much further. Also, community connections, knowing what organizations, be able to connect people, obviously in a HIPAA compliant way, but being able to understand the communities and the cultures that our patients are coming from. Medication tracking is huge. We would not be able to have injectable PrEP or injectable HIV treatment if we did not have case management and community health workers. There is just no way. They follow up with the patients, they schedule their appointments, they make sure that their medication is here when they need it, they fill out the applications for the patient assistance. There's just no way that that would happen without our community health workers and our case managers. Outreach. Our folks do an incredible job of outreaching to patients. They are able to see, who has been in and call and follow up with them, even if it's just sort of a casual wellness check. Hey, how you doing? And that really creates these interpersonal connections. I am amazed at how connected our case managers and community health workers are with some of our patients. A lot of our patients have their case manager as their emergency contact. That is their person that they want to be contacted if anything happens. We are often the first people to know about big life events, and that really creates a community around that patient to support them in a much larger way than just coming to the clinic. Our community health workers and our case managers do support groups, both in English and Spanish. The majority of our patients are Spanish speaking or are better served in Spanish. And being able to be in a support group with other folks who, are like you, who have, again, lived the same experiences, being led by someone who understands is invaluable to our patients. And if any of our case managers or community health workers are on this call, thank you. You all are amazing. All right, now I can pass it on to Martha. Oh, yes, these are my references.
Thank you. Thank you very much, Jacqueline, for your very insightful presentation and very thought-provoking data that you gave us a look at. I truly agree with your assessments. Your clinical expertise, your leadership and dedication does show, especially as you advance the equity in HIV care in your population. Now, with this, I would like to introduce our next speaker, Ms. Marta Robles. Ms. Marta Robles is a peer navigation coordinator at Christie's Place. Marta will discuss with us her role in community healthcare workers play in HIV prevention and care, particularly the challenges that her patients face regarding stigma, insurance barriers, language access. She does work in San Diego, so she has a very heavy Hispanic community, and she has been using her own experience with HIV to help guide and lead her patients. With that, I would like to let Marta Robles initiate her presentation. Thank you very much for joining us.
Thank you so much for the invitation as well. I'm very excited, a little bit nervous, but excited to be part of this panel. I believe it's very, very important to talk about this, situations because it's a need, not only here, but all over the world, right? So thank you for that. Okay, slide. So I'm going to be talking about needs, approaches, and gaps for females with HIV. Next topics that we will be discussing: demographics, overarching needs for a woman with HIV, description of challenges, barriers to care, emergent needs, and models of care that address barriers. Next one. So this is our model of care, community-based home. So like you guys can see, it's not a building, it's not a clinic, it's not a hospital. It's just a regular house. There's no signs outside. There's nothing. And I think that's how we kind of started with our mission, because we believe in, not only, especially for women that are a little bit more scared about being diagnosed with HIV, we work a lot on confidentiality. So every time they come, they feel like they're coming to their home, right? I mean, as soon as they open the door, you can see the front desk and then a little bit of information. But we have a living room, we have a kitchen, we have coffee, everything they need, so they can feel comfortable and make them, return or come back. And this is actually a little bit of our history. So Christie's Place is a leading nonprofit HIV service organization in San Diego, California, that provides comprehensive HIV/AIDS education, support, and advocacy. Our mission is to empower women, children, families, and individuals impacted by HIV/AIDS to take charge of their health and wellness. I would like to mention that Christie's Place has been open for 29 years now. And so we serve women and their families that are, women living with HIV, but their families that are affected with HIV. Next. Statistics. Next one, please. So California and San Diego County, the HIV statistics, it says that in 2019, there were 4,396 new HIV diagnoses in California. So that means 50% were among women, 12% cisgender, and 3% transgender women, because we also assist transgender women. And Black and Latinx women are disproportionately impacted by HIV in California. So women age 25 to 34 had the largest proportion of new HIV diagnoses among women in California. So in San Diego County, the proportion of women diagnosed with HIV has increased from 10% to approximately 13.8% from 2019 to 2023. So North Island, Central, and East regions in San Diego County have the highest proportion of new HIV diagnoses among women. And 75.1% of women living with HIV are in care. Thank God. So, and evidence by at least one CD4 viral lab in the last year. And that's one of the things that we do with our clients. We request labs at least twice in a year, depends how they are. But that's how we kind of, not control, but be behind them and make sure that they're going to their medical care. And if you guys need some more information, there's some resources down there. The next one. Okay, Christie's Place demographics. So as we can see, African American, it's only 60%. And then Hispanic Latinx, we are the 54%, which is, for race and ethnicity. We are like in a high level, but also I would like to mention that I'm right here like 10, 15 minutes from the border. So we have a lot of, Hispanics or Latinos around here. Especially because we're very near to them. And thank God we have a few clinics around here, but we are, right now, we're very connected with them. So we're working on that. Age and races of clients, also African-American and Latin or Hispanics women are from 55, 64 and up. Those are the clients or patients that we receive all the time. Once in a while, we get like, I don't know, recently I just got a 24-year-old woman, and but it's more about 55 and up. So these are the challenges and barriers. And I would like to say that I have been working at Christie's Place for 15 years. I'm also a woman living with HIV for 25. So when they offered me the job, I was not even, I could not even speak English or, move a computer, but they said, this is going to be your best, education and your best school. And I'm like, okay. And you know what? I was able to see all those barriers and needs of women living with HIV because I went through all that. And I think that's how I got so passionate to be part of this organization. So the barriers that we have right now, especially housing, it's like right here, San Diego is so expensive. We all just wanted to run. If you don't have like other let's say your kids or your husband or someone to support you with housing is very difficult, but also to find a place for, especially our community that are not, like they're aging already, they cannot work or things like that. Um, so therapy and support groups. Um, it's not easy because many times when we offer like therapy, they think that we are saying, okay, you need to see this person because you're crazy, right? They take it on a wrong way. So we have to explain to them, this is not because you're crazy. This is just to talk to a person that is going to put name to your feelings, to your emotions, and I think that kind of help a little bit. And also support groups. They're not too comfortable coming to support groups or going to any support groups because since in the middle of those support groups, sometimes other things go on, or sometimes they're mixed and they don't like to go to those support groups. Transportation, that's another one. They have to pay all the time, and that's the thing. For them, many of my women that I work with, they don't even know how to read or write, so we have to teach them how to use the transportation. In our case, we have that support, and I'm going to be talking about that a little bit further. And but transportation is one of the barriers. Child care. If they don't have someone to take care of their childs, they're not going to go to the medical appointments. They're not going to go nowhere else. And the language barriers. That's a huge one. I always recommend, because right here, my experience is that when they go to their medical appointment, they have, like those machines where are the ones that are translating for them, but they never kind of translate you know, the right way. And then for them, they're kind of scared of that machine, right? Because they're just hearing a voice. So that barrier is right there, and they don't want to go back. Also, many of my women are like, they have to kind of deal with women instead of a medical provider that it's a male. I mean, that's my experience with them. So for them, it's like, even if they understand them, they always say that or got that excuse. So we need to be there for them and translate their own language. Isolation, we have a lot of ladies, especially the ones that we are aging with HIV. They're very isolated, and they stop on medication and everything because they don't have nothing else to do or nothing like for any reason to continue, right? So they're that's why they are isolated, and that's where we go in and bring them out. Stigma, that we have a lot of clients that still not being open with their status, and that's pretty sad for me because it's like, okay, we work a lot with them, especially internalized stigma, because they don't want no one to know about their status. Next. So new and emerging needs. So this is what we do. Well, we do a lot more than this, but this, I feel that this is part of what it helps my clients or our community is to empowerment and leadership. So we do a lot of trainings for our women. One of the training is called Lotus training. So that's what we do. We train them for 4 days, and then we make sure that at the end, because they graduate, they receive also an incentive at the end. But all the things that we talk about, it's about the status. uh we do a lot of how do you say, a lot of, we focus a lot on how they can empower themselves so they can continue out there, but also not only for HIV, but also for other areas, like not being alone and stuff like that. And then at the end, they graduate, like I said, they get an incentive, but we also offer them like to be a leadership in the community. So we offer them to be a health promoter or promotores de salud in the community. They can do outreach with us. We also encourage them to be part of the county, care plan and stuff like that. And many of them, they accepted, and they're sometimes the language barrier, like, oh, but I don't speak English. Yeah, I didn't speak English when I started here, so you can learn there, right? But they also have translation, so no, that's not an issue. My favorite is peer navigation. That's the one that I'm in charge. So this is just a group of women living with HIV, and let's say that I got newly diagnosed. So I assign that client to one of my peers so they can follow up with them, especially if they're newly diagnosed. So we don't want them to get scared, to get traumatized. I'm the one that does the first intake. So I have to make sure that that client understand that, okay, here we are. And yes, we got HIV, but doesn't mean you're going to die. So I have to educate that person and then make sure that she understands about the process and what all she needs to do is to keep herself, under care and be okay with it. And at the end, I share my story with them. And thank God, most of the time I make them laugh, but also create a relationship with them so we can continue on their medical care and everything. We also culture, humility, and trauma informed care. We are very trained to do that, especially trauma informed care, because I was, like I said before, I used to learn at Christie's place, but I also in the past I was just using substances. So I'm a recovery addict, but also I'm a survivor from domestic violence and other things. So I learned that I can survive and I can help others. So that's why we trauma informed care is very important for our organization, especially for all the community that we work in, because they all going through all those stuff. Next. The next one. Okay, so now we're thinking of solutions. So we address immediate needs in ways that preserve dignity, provide information, access, and or referrals to housing, transportation, childcare, food, and clothing. We try to do everything the same day. We also have medical case managers, and even that they're not living with HIV, they're very, very special people that understand our community. And like Dr. Jelly said, it's important that we understand our patients, our clients, that we can make that empathy and make sure that they feel comfortable and that we are on the same level. There's no one better than you. That's why we don't use like uniforms. We don't use like name tags, none of that, because we want them to feel that we are the same, and that's very important for us. So the referrals are right there immediately. For medical case management, we also have a therapist, mental health, and I love this therapist because she does therapy sessions in a ranch with horses. So that's a very, very good, engage, because they love horses, and they go like twice in a month, one in English, one in Spanish, and they just like enjoy that. It makes a big difference for our clients. Transportation, we, like I said, the peer navigators, we transport them, accompany them to their medical care, and we are with their permission, we are in the appointment in case that they need translation, and in case that they don't want to say something that is not, that they don't feel comfortable, but we ask for permission from the client, and can I talk about this, and they say yes. So that's when the medical provider is like more, oh, there's more connection, there's more help for the client, and also a lot more support for the provider. And we have childcare, so we can just go to any clinic anywhere where they have their medical appointment. And we have like emergency food, and every third Friday of the month we have the closet, which is everything under donations, and we have a lot of clothing, and they can just come and grab whatever they want. They can take everything if they want to, and a lot of other stuff. So be rooted in trauma informed care. Understand that many women have experienced trauma that has prevented them from successfully achievement and health and integrates. So practices in all levels of care. So many of our women, like I said, they're aging already. So, they never had a place where they can just come in and talk about what's going on with them. And also they're not too open to kind of talk about their traumas and stuff. So that's why we do a lot of support groups. We do a lot of studies. We do a lot of focus groups so we can learn from them and kind of bring what they need. We do a lot of presentations regarding, I don't know, HIV, menopause, a lot of stuff. And that's when they can recognize all their, traumas and their needs as well. Next one. And also addresses stigma and isolation. So we have to continue involving women in support groups. Like I said, we have a lot of support groups. We have a art group, and this is more about, for ladies that are over 70 years old. But also they were women that were isolated. And so when we started this group, they just started coming, and they have like 3-4 hours to do art. They have lunch, they're laughing, and because the room is very near to my office, I can hear them every Tuesday laughing as loud. And I just have to go and check on them, and they're like, oh, right here, we're here, we're happy. You can tell the difference how that support group helps them. And also we do the educational presentations and share social experiences and allow them to learn from one to another. So that's their time. They don't have to talk about HIV. It's just their time doing art and talking about what's going on in their lives. Because some of them they're living by themselves. So that's the only time or special place and safe place that they have. Provide whole person care, women's health go beyond HIV. So address emerging and health needs and consider population-based healthcare. So like we all know, there's many different levels on where the clients are. And I would like to say this because even though we have a lot of ladies that are over 70, we also have, not too old, but also they're kind of isolated, but also hiding. They don't want to come out, or they just, they have their own beliefs, and they stop the medication because God is not approving that. And so we have to be behind them. Sadly, sometimes those clients ended up at the hospital, but as peers, we can be there and talk to their medical provider and yes, following up, yes, continue on kind of, empowering that person. And we almost lost this client, but recently she just went to the organization and we saw her and she's like, okay, Marta, finally, I decide to start my medication. So every person is different, but if we are there, especially a woman living with HIV like them, I think it makes a big difference because they can trust us. They can believe in that. Next one. Okay. So, I mean, we just recently on Sunday, we came back from the women's retreat. So during the year, we do a lot of other stuff. Um, but the women's retreat is one of the special ones, and we do it every year in September. And we were 75 women over there. And there was 29 ladies that were coming from LA, African American women, and then the rest from San Diego. And it's just amazing how do we transform those lives, right? And we haven't lived yet or left the place when they're like, Martha, I'm ready for next year. I'm like, okay, yes, go home and rest and we'll see you next year, right? But I mean, it could be like nothing for some people, but for us, it means a lot. Like transporting them to the medical care also, because that's my time with them to kind of, acknowledge, but also talk to them and see where they at, what's their concerns. And sometimes, like I said, they don't talk to their providers, but they talk to the peers. And if I see that there's a red light, I can just ask, so is it okay if I talk to your provider when we're over there at your appointment? And they're like, I don't know. Okay, think about it and just let me know. You know, some ladies that are like going through domestic violence, the same situation. Just, educate them and open those doors to see when they're going to be ready to start the, any process, but also making sure that they're not alone. I always tell them, you're not alone. I'm also a woman living with HIV, and this is all it matters for me is for you to be stable and be healthy. And just think about, you're not alone. You got your new family, and we can just walk together. And that's like they start crying, and it's just amazing. We do a lot of outreach, a lot, a lot, a lot. I have also promotores de salud group. Right now, we got like 12 people. This is mixed. This is for people that is positive and people that is negative. But we train them to be health promoters out there and talk about our organization, but also we talk a lot about PrEP. Right now, we're getting trained for that because many people is like, when we offer the test or anything, they're like, we don't do the testing, but we make that referral. But when we talk about HIV, it's like, oh no, mija, I just have one partner. It's like, that's how it happens to me. 22 years with this same person, and that's how I got it. Or sometimes I just ask, the community, do you know how HIV looks? No, yes, oh yes. Will you think that I'm HIV positive? No, no, no. Look at you. You're so beautiful and you smell so good. And I'm like, okay, you're my target. See, so I believe that all those things are helping. So now there's a lot of organizations that recognize us. They make a lot of referrals. If they're newly diagnosed, the county send it to us. If they cannot come to the organization, we can just go and do a home visit. We can do anything. And I know I talk too much, but I'm just excited. Thank you so much. If there's any other questions.
Well, Martha, thank you very much for sharing your experiences. Thank you for this very impactful, insightful presentations. I'm sure your patients love you and appreciate all you do for them. This is very good to kind of bridge the gap between what communities do and healthcare system. Myself, we see it a lot with our own community case managers. We also have outreach coordinators that help out. And nothing lights up the room in a patient's room when you walk in and you talk to them in their own language. They're
Mhm.
like they're super happy, no matter if you're talking Spanish, Polish, or whichever language, and they finally can since they can talk and understand someone, and they
Mhm.
can tell them what they feel. And our community is very diverse, so there's a lot of different people from a lot of different areas. So sometimes
Yeah.
they're very glad to see somebody that can at least talk to them a little bit.
Mhm.
Also, for me, one of the things that I have enjoyed a lot and is the collaborative work with the case manager, healthcare workers, other members of the group, pharmacists, and everybody. Because as a physician, you don't always get the whole story. You get part of it, mostly what the patient wants you to hear, because they want to be kind of in your good side, for example, they feel that way. And they will tell you a lot more to the case manager, case workers, the outreach folks. They'll tell them a lot more. And when the team works together, you really are able to take care of the patients more. We also are trying to, so this is for other places, we also try to outreach other health centers and associations in the community that may be doing outreach, like the food banks, for example, kind of giving the clothes, like Martha was mentioning, that we don't do at the hospital system, but we can get them connected to the same thing for like dental care and other services that the patients may not have access to within our health system. That's, I think, is a very important thing. Um, with that, again, I want to thank both Jacqueline and Martha. This has been very insightful, very thoughtful, and I'm sure your patients love the work that you do for them. I would like to open it up to some questions that have come up online, and I do like to make sure that everybody questions come up. Please feel free to type it in. We'll be more than glad to answer any questions that we have. The first one that came up for both of you is by one of our attendees, indicates in terms of demographic data and community approaches, how is the experience in the Afro Latino community? That is the Black and Hispanic populations. How are they represented? How are they captured in your sites?
So I mean, the data that I showed was uh, was assembled by a group at Emory that takes reports from different health departments and puts it together. So I am not clear about that. We do, when we collect data for my organization, when we look through, we do look at folks if they identify as Hispanic, Latinx. We do see if they identify as white or as Afro Latino, and we do take that section out separately. But as far as the national demographics, I'm actually unsure.
All right. Martha, do you have any thoughts about how you do you approach differently the populations, the the Hispanic populations?
Uh, mm, no. I think also I think this is more part of my boss doing all this, but also we do a lot of studies. We participate also a lot in a lot of studies, so we can see how the population is going. Yeah.
No, thank you. No, one of the things I do see, kind of to answer this question too, is that the perception of races within Hispanic communities is a lot more varied as well. And a lot of groups identify more as the country of origin as well. Like Guatemalan will not look, it will feel different than a Salvadorian or a Puerto Rican and a Cuban. And within those communities, there's Afro Americans, there's Hispanic, there's also a lot of what we call Native American mix within there, mestizos. So there's a lot of more variety in the sense that it depends a lot on what the patient represents itself. But I think for a lot of them, the primary representation is that they're Hispanic and then what country they come from. But it's a big deal. We do try to address that because not everybody's the same. Um, Another question, just to kind of touch base for both of you, how can healthcare professionals, particularly, foster the trust and communication with Spanish-speaking communities? How can they get, around the topics like HIV and perhaps other topics that are sensitive in the community? How can they do that?
I mean, something that I think is really important is, if possible, learning the language and being able to speak Spanish. Um, Also, just feeling comfortable having those conversations. A lot of my folks who are new arrivals have never had a sexual history taken by a provider. That's not something they're accustomed to. But the fact that I'm able to just ask them the questions and feel very comfortable doing that helps a lot. Also, I think having especially for our folks living with HIV and our PrEP folks, our community health workers contact them first and let them know that, kind of prepare them for this part of the visit. And I think that that kind of collaboration will really help too.
And for me, I would say, and this is one thing that we are kind of pushing it right now over here in San Diego, because we still have some providers that are HIV, specialists, but they still like telling our clients, take care of yourself. So they don't know how long they're gonna still, alive. And those are things that, come on. I'm almost 59 and 25 living with HIV and I still here. So we are what we're doing, looking for those opportunities to, yes, go and do presentations for the medical providers, at the colleges and all that. They allow us to do that. We recently went to do also for it was also medical providers. Now they were getting ready to be HIV providers, and I think that's one thing that they need to hear from a person living with HIV, that this is the need. Be more sensitive, don't be too rude, because we got our providers that are kind of just they don't, there's no empathy, no feelings, and that's pretty sad, especially for women. All right. And so that's what we do a lot. And also we also educate the women to go and talk to their providers. And you can tell your provider, can you please explain this, or can you please be more sensitive, can you, and that's another thing. And that they're doing it. So we also do the trauma informed care training. for any organization, especially with medical providers. That's what we're doing right now as well.
I definitely agree with both of you. I think that's very important. And I'm very sorry that there are providers that don't connect. Some of my patients, including one that was 87 years old, lived with HIV for almost 30 years. And he was fine. He was a very nice patient for Puerto Rico that did very well for a long, long time. One of the things that has been brought up as in the question is, are there any new strategies or what are you doing locally to kind of help to keep the patients engaged with HIV and also keep them in a continuation of care right now with the new changes, with all the funding differences, and how you can keep them connected to PrEP?
I guess I can take that one as first as well. I mean, we're fortunate. I'm fortunate to be in Illinois, which has some additional programs, especially for PrEP. Beyond that, just kind of educating patients, educating folks about their rights. Folks who do qualify to be on any kind of public aid, we're trying to get them signed up for that, and just really educating patients as much as possible. Some of our folks right now in Chicago are a little bit concerned about coming into the clinic due to increased federal presence. And so we are increasing our telehealth visits to allow folks to still access care while not having to leave their homes. And then we're just kind of doing everything that we can at this point.
For us, I think it's a little bit the same, but also we are we use recently one organization offer us like a grant so we can work together with them as peers and working like on the community to pull people, you know, to start PrEP, which is something that we're looking for. And it's going to be, I don't know when we're going to start, but I know that my boss is like very engaged with that organization, and we want to start doing that. But also, like the doctor said, it's right now because of eyes and all that situation. It's so concerning. The good thing is that we are a house, like I said, so we are a private place, so they cannot come in, and we already have some signs and everything. And the other good thing is that we can just go get them. You know, we I feel that we are privileged that we are allowed to do a lot of stuff for the communities if they're living with HIV or if they're not, you know, because we have a lot of ways to do things for them and support them. And until now, I heard that you know, we all still getting the medication without a problem. A few clients, they just kind of changed from medical to runway, right? And but we are just like, you know, just checking on them.
No, we always try to do what we can. Similarly, in our clinic, we do a lot of transitioning patients into healthcare, finding them where they can get connected to full insurance or get some sort of insurance assistance. There's one question that I'll answer quickly. We will touch on the toolkits or support. There's a lot of information that we have for Hispanic patients and handouts that we will provide available through the NHMA as well, that are both in English and Spanish. Again, thank you both of you, Jacqueline and Marta. We really appreciate the data and the very lively conversation. With that, I'd like to kind of move on to some of a couple of things with CME. Just as a reminder, your CME will take about a week to come through, and you can also to receive your credits. Also, you can send an email or a connection to our facilitators to be able to get that information as well. Next slide. We also like you to answer a survey, see how you like the presentation, the webinar, see if there's anything we can do better, any topics that you may be interested in to listening to in future seminars or webinars. Next slide. We also would like to kind of, again, lead you to some of the connected information that is available. There's still information available to CDC, still there. Well, we also have our own information to the National and Hispanic Medical Association as well. And all the information is referenced so that you know that the information is valid and something that patients and providers can both use. Next slide, please. So we have an update on the side, which is the role of pharmacy in HIV prevention. This will be on February 18, 2026. Please mark your calendars if you're interested. Next slide. And this is our social media page. We have lots of ways you can reach out to the NHMA to both, if you want to get more information, we got the upcoming webinars or data or Hispanic data, things that are translated or anything else that you'd like to reach us for, and keep yourself informed of events that we'll have. Next slide. And again, to reach the Hispanic data that we have and the tips, you can go to hispanichealth.info. That provides a lot of those tips that you may need that may be useful for patients and providers as well. Next slide. And always welcome new members. We love to have some of the folks that participated in the call today join us. Again, we work as a community. We try to bring in not just physicians, but healthcare providers, healthcare workers, medical students, residents, everybody into our group. Especially, we're looking to kind of make the new leadership, empower the new leadership that will help us bridge the gap for Hispanic and underserved communities. Next slide, please. And again, another options that we have, NHMA provides lots of opportunities. And if you are graduating, you're looking to join a community or a provider that involves in Hispanic care and underserved communities, look at our job board. We have lots of jobs posting for people that may be interested in these. And we have lots of job connections with providers and employers. Thank you. Next slide. And here's our final contact information for you to reach out to us. And please feel free to do so. We'd like to really thank you, all of you, for participating in today's webinar. It was excellent presentation by both Jacqueline and Martha. We enjoyed your share experience and and we really thank you for all the service that you provide to your patients in your communities. It's invaluable. Thank you very much. And with this, we'll be completing our seminar today. Thank you very much for participating.